So let's start. Dear friends, welcome in this glaucoma session. I have the honor to be with Dr. Founti, who is glaucoma consultant in Moorfields Eye Hospital, and Dr. Lim, who is the head of glaucoma service at St. Thomas Hospital. The first lecture will be by Dr. Founti about the monitoring glaucoma with visual fields, pits and falls. Then Dr. Lim will talk about the mix in glaucoma, and Panagiotis Founti at the end will give us a lecture about the monitoring glaucoma with imaging, pits and falls. So, Panagiotis.
Hello, thank you. Καλησπέρα. First of all, a big thank you to the organizing committee. I'm very humbled to be invited and to have been included among such esteemed speakers. And lovely to see many good friends and colleagues. So I have no financial disclosure with this talk. Yesterday, I presented a summary of the basic principles in the management of glaucoma, covering all of these topics. The only thing I didn't talk about was the monitoring with the field and the imaging, which is what we're doing today. The reason why I'm saying that is because a large part of the new knowledge about the diagnosis and everything was covered yesterday, which is why I'm not going to go into too many details today. So we're going to talk about the basic principles, tools, and clinical cases. The plan is to keep it short and comprehensive. The clinical cases are all from my clinic, everyday cases, not very complex, everyday primary open angle glaucoma cases. So the basic principles, it's all about the visual field. At the end of the day, this is why we're treating people, to keep a long life of vision. And we know that when it's getting even worse, the visual field, the quality of life gets worse. There is this misconception that people are not aware of the visual field loss unless it's very bad. But it's not true. There is a perceived level of disability even with early glaucomas. And of course, this is false. People don't see like that with glaucoma. What they have is missing information from the background. So this is the normal visual field. I showed this yesterday. A person with glaucoma and a visual field defect here is going to miss the little kids. And when this gets worse, they're going to miss a little bit of that, and a little bit of that, and a little bit of that. So obviously, they don't know what it is that they are missing. But detecting change is very challenging. First of all, because we haven't agreed among each other as to what is change compared to the noise of the results. And also, we don't know exactly which method or criteria is best. Whenever we do a field, even with normal vision, every time we do it again, it will be a little bit better or a little bit worse. And that is also true for the glaucoma patients. This is a very good example of what's happening with a test when we retest it. So this is, let's say that this is no glaucoma. This is very bad glaucoma. And this is the threshold of sensitivity in the visual field. So if you have a little bit of glaucoma and you're here, and you do the test again, if you are within this zone, up or down, that is considered to be normal variability. If you have advanced glaucoma and your visual field is down here, anything within the zone, up or down, is considered to be normal variability. So when your patient has a lot of glaucoma and the next visual field is bad and he's already here, it is not possible to know if they're worse or not. You can assume that they are worse if the pressure is high or if they're telling you they're worse, but in reality, you need a very clever machine to tell you that. And even among us, we are very bad at agreeing with each other. So the thing that we all do, myself included very often, with the visual field chart flipping like that and saying, yes, you're fine, or no, you're not. It is completely unreliable. There are two ways that the computer can help us with visual field. They can tell us if there is progression, and they can tell us how quick the progression is. So these are the two forms of analysis that we get from the field. These two forms of analysis, they answer a different question. And when you are assessing the patient with an events-based analysis, the question is, are they worse? Yes, maybe, no. Is there statistically significant difference from change? And then how do we measure that? If we want to measure it over time, we need the trend-based analysis. So with a trend-based analysis, the machine will tell you how quickly is this visual field getting worse, which could be very quick or not very quick, depending on how old your patient is. I remember very well that when this was introduced, it was all about the trend-based analysis being better, or it's not true. Both are very important and equally useful, and we'll discuss some cases about that. So how often should you monitor the visual field? There are guidelines about that. Some people say if it's worse, you need to monitor more frequently. There are guidelines like in the UK, which have these algorithms that nobody ever uses. But the truth is that how many visual fields you need to do depends on what it is that you're trying to detect. So what kind of change are you trying to detect, and how quickly do you want to detect it? If you want to detect a change of 4 decibels, which is a lot, and if you want to detect that in 2 years, then you need 3 visual fields per year. Alternatively, if you want to detect a very small change, like if you want to detect a change of 1 decibel, and you want to detect it in 2 years, you need to do 7 visual fields per year. And for that reason, we are not trying to detect very small changes when we first diagnose patients. We're trying to detect big changes. So we're trying to detect those who are getting worse fast. And once we find those, then at least we know who is at risk and who is not. This is why the recommendation is, that's how this came out, the recommendation of 3 visual fields per year, which is already a lot. And I must say that even at Moorfields, where we have all the machines and the resources, it's very difficult and very expensive. Okay, so the tools. I won't go into details, but I'm going to present you what is out there. This is the Progressor. It's a software developed by, a software developed by Ananth Visuanathan, who's a consultant at Moorfields. It gives you a color map, which is a little bit difficult to understand at first, but basically every little square is an area in the field, every bar is a test, and the longer the bar, the worse the defect. Another easy way to remember how to read that is, if you're getting a lot of white and red, that's bad. If you're getting anything else, it's fine. If you're using an electronic patient record, like my friend Angeliki sitting over there used to in Medisoft in Bedford, you're getting something like this. So that's also a very useful tool, is an analysis using the EMGT criteria incorporated in the electronic medical record, and you can get the analysis for a patient. This is Octopus. Many people use that, I think, in Northern Europe. I'm not sure if it's popular here. But the one that most people use is the Humphrey visual field analyzer. This was developed by Anders Hale, who was also the principal investigator for the early manifest glaucoma trial. It is very widely used. It gives you both kinds of analysis. And the way to get that is to go to print functions, which is here. Oh. Excuse me. Yeah. So print functions, you put the patient's name, you select the most recent tests, and then you press analyze, and you get this. All of these are types of analysis that you can do. Do not choose print all selected items, because you're going to get a 30-meter printout, which nobody needs. So the one you need is the summary. That's the most popular one. The summary looks like that, the report. On top, you have the 2 baseline tests, the first 2 tests. In the middle, you have the graph of the visual field index. We're going to talk about that in a moment. And at the bottom, you have the change probability maps. So this tells you what it was like at the beginning. This tells you how quickly it's going. This tells you, are you worse or not? The baseline. Always a good idea to check. If your tests are completely unreliable or if they're too far apart, then it's a good idea to choose 2 different tests as baseline tests if you have enough. Also, if your patient has had something major like surgery, you need to change this and maybe get rid of these 2 and put as baseline the first visual field after the TRAB or the immediate before the TRAB. The visual field index is a I'll show you that in the next slide. So the visual field index is a measure of how bad the field is overall, and it is measured in a scale from 0 to 100. So what you're getting here is a plot of this index over time, and if you have enough fields, you can get a 5-year projection of what's going to happen. It's supposed to be better than the mean deviation, so if your patient has a lot of cataract, it's not supposed to be so much of a problem. The reason why it's supposed to be so clever is because it's a weighted measure. So the central areas of the field are more important than the peripheral ones. So you can have a big scotoma, so low mean deviation, but your visual field index may be high because the scotoma is peripheral, whereas a smaller scotoma may give you a lower visual field index. Generally speaking, you don't want the VFI to fall below 50%. And anything below 30% is very advanced glaucoma. And then the change probability maps look a little bit like that, and you get the triangles. So if you have 3 points getting worse in 2 follow-ups, that's a possible progression. It's a half black triangle. Either getting worse in 3 follow-ups, that's a likely progression. Clinically, it is progression, and it's very sensitive and has good specificity as well. But remember that every time you see that there is a 5% chance of that happening just randomly. So when you're doing a lot of tests or a lot of points in the field, and each one of that has a 5% chance of being falsely highlighted as worse, then it's very likely that you will get those, which is why you should not rely on the individual ones. You should be looking for clusters. The overview gives you the field, just a picture of the field. It's very useful if you are monitoring non-glaucomatous damage. It's also useful to show your patient because they can understand that. And that's what I'm going to talk to you about. So I have a couple of cases that I can show you, and then if we have time, we can discuss the rest at the end. I'm going to keep this very brief because the important here is to discuss the field. A 74-year-old patient with primary open angle glaucoma and pressures around 20 on 3 drops. This is the OCT. Any comments? Miss Salonikiou, any comments? I mean, it does look like bad glaucoma, doesn't it? I'm sorry? Possibly unreliable, but actually I would say that, first of all, both RNFL OCTs are abnormal. The pseudo-image of the OCT shows that these are abnormal discs. I mean, it does look like glaucoma. It does look like bad glaucoma to me. So this patient has glaucoma, we know that. But the visual field is not that bad, actually. And that's quite common, this poor correlation between function and instruction. This looks worse with a notch inferiorly. So it corresponds very nicely to that. And these are the change probability maps. This patient is getting worse, yeah? Clusters of black triangles here, clusters of black triangles here. So a patient with pressures of 20 and primary open angle glaucoma getting worse. What would you do in this case? Would you give more? Would anyone give more drops? No. Would anyone do a trabeculectomy? Yeah? Great. So which eye would you operate first? This patient will need to come to your practice every week for the first couple of months, well, first month, and then after 3 months, you will do the other eye. So, or maybe 2 months. So which eye would you, would anyone do the worse eye first? Would anyone do the better eye first? In some cases, actually, it may make sense to do the better eye first, because some people are not willing to have surgery twice. So if this is very bad, it may make sense να σώσετε το καλό μάτι. Well, to save the good eye. But here, what you really want to know, of course. Fair enough. You can save some of it. Absolutely. Now, what if I told you? Absolutely. Now, what if I told you that this is worse, but this is getting worse more quickly? Obviously, we'll go for the best. Right. Okay. Well, in this case, if you see the whole printout, the left eye not only is worse, is getting worse a lot faster. And that is how you would say that I would definitely go for the worse eye. Not necessarily because it's worse, because it's getting worse quicker. And of course, if the pressure is similar, it will get worse quicker because it's bad already. And here you can see that this patient is losing almost 4 decibels. Sorry, excuse me, it's not decibels, it's percentage of the VFI, but they're going down quickly. The other thing I wanted to say is that the numbers, the exact numbers, are necessarily not very important. I mean, if you have a good understanding of what the field shows you, whether it's 3.2 or 4.1 may not be that important. Bottom line, you get good information from the event and the trend-based analysis. And other information, then, it's not as important. I mean, what's the CCT? Who cares? This patient is getting worse. He needs a trabeculectomy. All right. Should I present another one? Yeah, okay, let's do another one, a quick one. Right, yeah, right. I remembered. So this is true. This is from one of my patients. So this is the right eye, this is the left eye. And when I saw this field, I thought something doesn't make sense here, because the top part says progression, right? -4. So this patient is getting worse. But when you go to the bottom, not much happening there. I mean, there are a couple of missing points, there are a couple of black triangles, but it's not really that bad. So what's happening in this case? Why would a field show this and this? And then I thought, let's have a look again at the baseline. So this patient had 2 visual fields at baseline. Both of them are unreliable, but the right eye, the first one, has a high percentage of false positive, so it looks a lot better. So when the machine set the baseline for the VFI graph, it started higher, which is false. So it started higher, and your patient is here now. So maybe this patient is getting worse like that, but because your baseline is problematic, the slope goes down like this. So this is a case where you need to go back to the machine yourself and remove the baseline, the first baseline, and choose another one. That's a very typical example of how he is getting worse, but not that quickly. Should I stop and then maybe we can do some more in the fan club? Yeah, thank you.